Thank you, John, and everybody for inviting me here. Yeah, this is one of the hottest topics in a complex setting. So when and how shall we use DCB? I will try to convince you that we should think at this option, but we shouldn't be stuck on it. So if you see, do you see my screen?
Yes.
All right. So complex PCI, we have to remember always, and this is something that I overemphasize, that the stents that we are currently using have not been tested sufficiently in a very complex lesion settings. And it's quite clear how hard events are higher when we employ them in a current lesion setting of complexity. And all of the determinants of the events are increased. Okay, so there are several studies showing that, and this is especially true in the CHIP patients where the MACE rates are really, really higher. I want to overemphasize three aspects of stenting and the reasons why stents actually do fail in this setting. So first of all, the risk of stent under expansion is higher. We have calcific lesions like the one that you were mentioning earlier, John, where the stents, if you don't prepare correctly the lesion, do fail. Then we have long lesions. In the CTO settings, we have always long lesions. And here there is a direct correlation between the risk of target lesion failure and the length of the stents that you are applying. Okay, so we have to remember this. And the last concept is that stents are metal, especially after year one. In year one, they are better than bare metal stents, at least for TLF and TLR mostly, but after year one, they are metal. Whatever stent you have implanted, it's just metal. And a metal is a foreign body. So we have to consider this when we decide to treat our complex patients. DCB, I'm not going through the indications of DCB so far, but they are gathering more and more indications, especially in Europe and Asia, where the experience is now high with numbers that are increasing. There are centers which are using more than 50%. The DCB is in more than 50% of the cases. So we have to remember this. And last year, we had, for the first time, the publication of the DCB ARC, trying to dual aims, let's say. So one is to increase the scientific relevance of DCB by dictating which are the endpoints and how the studies on DCB should be performed. Okay, because so far we had, in the majority of cases, small studies with surrogate endpoints, so not that hard, not that scientific relevant. And the other thing is very important, is on how we should pursue a DCB angioplasty, because it's all about that. We have to prepare the lesion correctly. Then DCB is only the last part of it. So let's try to see how DCB are performing in the complex lesion setting. The first one is the diffuse disease, long lesions. So in this study, which was performed in Korea, and it's one of the pivotal studies of the last few years, a blended strategy of drug-eluting stents for 1/3 of the lesion and DCB for the rest was shown to be superior in terms of MACE at 2 years as compared to a full metal jacket in the diffuse disease. This is not a CTO study. This is not a severely calcified lesion study, but it's a diffuse disease. And it works. It works. So we don't have to stack on DCB versus drug-eluting stent. I want to use only DCB instead of stents. We have to think and reconsider the way we treat our coronary patients by reducing the stent length, but implanting easily stents, but reducing the stent length to the maximum. This is why blended strategies or hybrid, I prefer to use the word blended strategy of DCB, with a DCB as a first strategy with applying stents where we need, it should be used more and more for many reasons, like the ones that you can see here in this review paper that we recently published. So some literature data, we published this propensity matching assessment comparing DCB, in this case, this is a Siroli muscular balloon versus drug-eluting stent in complex lesion settings For complex lesion settings here, we included long lesions, more than 40 millimeters, severely calcified lesions, CTOs. And what we found after 2 years is that there was no difference in terms of MACE. So a DCB strategy with a bailout stenting, which was around 10%, was warranting us similar MACE at 2 years, with a reduction in bleedings and in the NACE, which was the primary endpoint of this study. And then we have the calcified lesions. We have few data that are coming. We have this study which was published. This is a Japanese study which was published recently and is showing how DCB can be considered as an alternative to stents. In this study, at 3 years, there was no difference in terms of clinical outcome. But the big question is DCB safe in calcified lesions? And the second question is, what shall we do? So can we use the same tools that we are using for drug-eluting stents also in calcified lesions? We tried to respond to this question with a cardiac study, which was presented by Daniela Benedetto last year at TCT a few months ago. This is a multicentric study with a severely calcified lesions with a solo DCB approach. So only DCB, no stents. We enrolled 134 patients, where about 50% of them underwent rotational or orbital atherectomy and 50% IVL with some combined strategies. And what we wanted to see was, first of all, is this a procedure that is safe and is it successful? So for obtaining this information, we had a core lab assessment of all of the angiographies of the patients enrolled into this study. And very interesting, I have to say that these centers were experienced in DCB. Very interesting, the post-procedural percentage diameter stenosis was as low as 24%, meaning that it was a good lesion preparation was pursued with this strategy. Dissections were 21%, so nothing specifically difficult. The other information that we gathered from the cardiac study is that the TLF at 12 months is quite low, 6.6% for these complex lesion settings, and we did not have cases of subacute or late thrombosis in the treated segments. I'm going to show you now in the second part of this presentation a case, which is a CTO case. It was not that complex, to be honest, but since I saw in the program that Roberto Garbo is presenting a laser case, I'm presenting also here a case that we performed a few months ago. So it was quite easy to negotiate this total occlusion ISR. We started pre-dilating with a semi-compliant balloon, and then upfront we decided to use laser. So in this case, we use a 0.9 millimeters catheter, Phillips, and we delivered an initial energy of 60-60 with 7 runs going back and forth, okay? Back and forth with very slowly, how you should do it for laser. And then we did OCT. So let's give a look to this OCT. Interesting, the stent was well expanded despite the calcifications in this procedure. We have neoatherosclerosis. We have calcified neoatherosclerosis inside of the stent, and we have diffuse disease. But interesting, the reference vessel was 3.2 millimeters, whereas the MLA was 2.5. So this is not a good lesion preparation for ballooning and then DCB. So this is why we decided to go with, again, with more laser, and we did this at 80-80 with contrast, 80-80 and contrast. So maximum that we can achieve with this catheter. And this is the angiographic result after laser, which is improved. And then again, you have to repeat the OCT, which should guide you in the complex lesion setting if you want to pursue a DCB result in your ISR or severely calcified lesions. And interesting, the MLA from 2.4 did increase to 5.6 in the ISR segment. So it's a matter of how you use the tools that we are having, because now we have very good tools to prepare the lesions. And then the rest is quite easy. We use the incremental non-compliant balloons up to 3.25 and applying them with pressures between 14 and 20 atmospheres. And this is the final result, which is pretty good. Then at the end, after you achieve a good final result, you can deliver the drug. In this case, we use 3 drug-coated balloons which could be an issue, at least in the US, for reimbursement. We use 303 by 305 by 30, and this is the final result that we achieved, which is pretty good. And then we reobserved it for in an orthogonal view after a few minutes. In the last part of my presentation, I want to show you which are the advancements for the usage of DCB in CTO, which is the most appealing setting, at least in my opinion, for their usage now. There is this meta-analysis published last year, which is showing how with small studies, gathering small studies, this is the big limitation, at least we can have the similar outcome as compared to drug-eluting stents at 2 years follow-up, which is pretty good, 2,000 patients. But more data from registries is coming out. First of all, we have the DCB ERCTO registry from Europe, which is showing how the usage of DCB is increasing in CTO. In 2023, it was 15% from like 3% in 2016. And this registry is also showing the safety of a DCB approach in terms of in a hospital outcome. But we wanted to see how DCB are performing better with a mid-term outcome, and this is why we performed this multi-center experience of Piccoletto 10. So in Piccoletto 10, we have a strategy of DCB plus or less drug-eluting stents. Again, we don't have to fear putting short stents. This is the key message. Only expert centers, consecutive patients. These are the centers that participated to this study, which has been presented at TCT, and later on, we gathered information for 938 patients with de novo CTO, 76%, 50% solo DCB, 50% DCB plus drug-eluting stent. And interesting, we had a procedural success of 92%, which is pretty good. I have to admit, this lesion setting is not the most extreme one. So the cases that you have shown today are more extreme and more complex than this. So this is a moderately or easy CTO lesion setting, which is the one where we can test the efficacy and the safety of a new technology. In this case, we compared paclitaxel to sirolimus-coated balloon. You can see here that the number of CTO wires used was 2.3. IVL was used in 11% of the cases. And as I said, the procedural success was pretty high, 93%. You can see that a JCTO, again, not that complex CTO cases, was 2.12, and small vessel disease was present in 51% of the cases. Interesting, of course, and not surprising. Interesting and not surprising, the crossing strategy was mostly anterograde wire escalation, which is something that, at least in my institution, we are trying to pursue more than other centers where the conversion rate to ADR or retrograde is higher. But if we want to pursue a DCB angioplasty, we should insist a little bit more for anterograde wire escalation. So this information is mostly related to this one, but we will do a comparison between the techniques in subsequent publications. Interesting. The safety of this technology, of applying this technology, is pretty high in terms of in-hospital outcome. And this is the key information. We have 1 year follow-up. This is the only study with 1 year follow-up of an entire cohort of 1,000 patients of CTOs treated with DCB. We have a pretty decent clinical outcome with a TLF of 7.5%. In this specific subset, no differences between sirolimus and paclitaxel-coated balloon. And again, no acute, subacute, or late vessel thrombosis. So my conclusions, DCB represent now an ideal tool to navigate in all of the complexities of coronary artery disease patients. But you don't have to stack on a decision, DCB or DES at the beginning. You have only to prepare the lesion, and then you take your decision in the end. And putting a stent, if it's short in a large vessel, is not a big deal. That stent is not going to get occluded, but you have to avoid full metal jacket. From a procedural perspective, DCB, you have to consider, may simplify the PCI in some complex settings by reducing total stent length and easing bifurcation management. Key is, as always, an optimal lesion preparation, but we have shown that you can use all of the tools that you have, atherectomy, laser, whatever, before applying DCB, specifically for the CTO setting. Now, what we need is a randomized clinical trial, which should be strategical, not just DCB versus drug-eluting stent, but a strategy based on DCB with short stenting versus full metal jacket.
Thanks, Bernardo. That's brilliant, and great to hear from you and your team who have such extensive experience with this. I think we're all learning, aren't we? I do wonder about the differences now between, we did stents initially because balloon-only preparation was definitely shown to be inferior, but balloon-only preparation these days is very different. We use calcium modification, we have imaging to get one-to-one sizing. What we accept as a good POBA result is very different to what it was 15 years ago.
Yeah.
And I'm not entirely sure how much of the positive results that come out of DCB treatment are due partly to that, and what is due to the actual absorption of these anti-inflammatory drugs.
This is a very good point, John. I respond with some scientific data. There are some studies, including REC-Cage-free one, where we show that if you mandate a high level and up-to-date lesion preparation, also for drug-eluting stents, the outcome is going to be improved. So that's key. Of course, now it's not a matter of, okay, I will prepare it just with POBA versus specific tools to prepare the lesions. You have to stack with whatever we have in the lab, and then, okay, we can compare the outcome between DCB and a full metal jacket.
Okay, great. Now, Bilal, very quick, because we're going to go to the center. Yeah.
So Bernardo, fantastic presentation, and I use a lot of DCB in my practice in CTOs, and obviously a hybrid with the DES and DCB works very well. I started using DCB as a pure treatment strategy in some of my patients, and usually we do that when you've used antegrade wire escalation and where you're confident you've got an intra-plaque passage of your wire. So in your presentation, you talked about 80% antegrade wire escalation. There was some RDR, I think 5%. I think an important question here is, what are your views on using DCB in extra plaque space? I've been using it. I've used it. It's a bit controversial. I'm building up my database of about 30 patients with STAR I have done so far, and follow-up angiograms are amazing. You've got these false lumens that have endothelialized. We know the endothelial progenitor cells, they're flowing around, and so what are your thoughts on using DCB in extra plaque space? Do we have enough evidence to use it, or is it still kind of out of the evidence base?
This is a hot topic also, and I agree with you that we need to gather more information. We will analyze the subgroup of the RDR and ADR that we have here. I don't have this information yet. What I can tell you is that if the, let's say, out of the lumen or intraplaque part is long, I would advise to use sirolimus coated balloons, because there have been reports that paclitaxel, again, if that's extensive and long, might increase the risk of ectasia and in some cases aneurysm. So that's the only thing. If it's short, you can use paclitaxel easily. But again, we should gather together our experience and have a registry of 200, 300 patients to say if this is safe or not.
Perfect. Just a short comment, Bernardo, a small question. Congratulations for your talk.
Thanks.
If use disease and calcified lesions, we have learned that maybe use DCB with image is better, because when you talk about optimal lesion preparation, sometimes in angiography, of course, it's difficult to be sure that that's the optimal preparation. So with image, you can see clearly the acute gain. And I think that must be a study in the future, if that can change, of course, the endpoints in the trials. I think the debate in image use in DCB must be focused in diffuse disease and calcified stenosis.
I agree, and as you said, it's nothing intelligent I have to add to what you said, because imaging there is key. like for ISR, 100%. So not like 90, but 100% of the cases you should use imaging. Now we have data showing that in the easy lesion setting, imaging is better also for drug-coated balloons. What we need is to have a randomized clinical trial, and we are planning that with Giulio Guagliumi to do a randomized clinical trial of guiding you with imaging until the end of PCI. So that's the future, but so far we have to use it.